Dear audience, welcome to this nice afternoon. I would like to present you my thesis subject, which is functional and morphological investigation of complex coronary pathologies, recent modalities. I work in the Department of Cardiology at Semmelweis University, and my vision is to reduce the burden of coronary heart disease with improved coronary interventions. And my mission is to decreasing the need of recurrent revascularization and the rate of complications. I have three specific goals during this year. First one is the drug-coated balloon effectivity in the treatment of early and late drug-eluting stent in-stent restenosis. This is a systematic review and meta-analysis. The second and the third one are both clinical trials. One is the radial artery puncture hemostasis evaluation, and the other is the optimal treatment for coronary in-stent restenosis. This year we planned to prepare the publications of the protocols of these trials. So let me begin with the RAF, radial artery puncture hemostasis evaluation. This is a protocol of one of our clinical trials, which we drafted already. The protocol, we actually compared three arms, two facilitated hemostasis devices with the gold standard mechanical compression device. And after the removal of these devices, we control the patients with ultrasound. We assess the usual endpoints used in the literature as radial artery occlusion, radial artery damage, or bleeding events. And we also control the patients after approximately 60 days with ultrasound evaluation. We actually published this protocol to the Frontiers in Cardiovascular Medicine this spring. It is a 6.5 impact factor journal, and as I know, it was the first publication in the center at Semmelweis University. So the clinical trial is at the status that we are involved already more than 50% the planned involvement. This means 311 from 600. We already are performing our interim analysis, and we would like to complete the trial, or actually the involvement of the patients, by next year. The second project is a systematic review and meta-analysis, which is the drug-coated balloon effectivity in the treatment of early and late drug-eluting stent in-stent restenosis. So, as coronary heart disease is one of the most frequent diseases worldwide, and the current state-of-the-art handling is to implant drug-eluting stents. The eluted drugs are somewhat protecting from the in-stent restenosis, but it still occurs about 10% of the cases. Then we have the two options to treat these lesions. One new layer of drug-eluting stent, or a drug-coated balloon, or DCB usage. DCB could be the future direction, but it might not be as effective in early DES-ISR than in late, which has a margin of 12 months. Our aim is to decrease the need of recurrent revascularization by these patients. So our clinical question was, does the time of DES-ISR occurring early versus late affect the outcomes of DCB treatment? We compared post-PCI patients receiving DCB treatment for DES-ISR. The two groups were early, so before 12 months DES-ISR occurrence, and late, so after 12 months DES-ISR occurrence, and the outcomes were major adverse cardiac events, as target lesion revascularization, cardiac death, and myocardial infarction. So our hypothesis was that DCB is more effective in late DES-ISR than in early. We performed a systematic search in the 5 big databases, and we found more than 800 articles from which we could extract the full texts of 4 articles. So we assessed 2 outcomes. One was the MACE, the major adverse cardiac events outcome, which is a composite endpoint of target lesion revascularization, cardiac death, and myocardial infarction. And we had an odds ratio of 1.68, which means that early ISR group had 68% bigger chance to get revascularization or any of the other outcomes as cardiac death or myocardial infarction in the assessed 1 year. The second outcome was target lesion revascularization, which is the biggest part of the composite endpoint. Then we found 69 odds ratio, which translates to 69% of bigger chance to having revascularization at early death ISR occurrence than in late. So to summarize this meta-analysis, we found the difference which is clinically and statistically significant between the two results. And the included studies could not present statistically significant difference alone. In summarizing these, we could show it. And relatively low patient number and event count is one limitation of this study. The reported data should be more detailed, actually, in the included studies. So if death ISR appears earlier than 12 months after the index procedure, more frequent patient screen is needed for worse outcomes. That's our clinical implication. And for research, more randomized controlled trials are needed on the subject of death ISR treatment with DCB, with the recording the time frame between the index procedure and the following clinical event. So the manuscript is under review now. It's submitted, and we have 2 target journals. So let me finish with the third project for this last year, which is the Open ISR Optimal Treatment for Coronary In-stent Restenosis clinical trial, in which we plan to publish the protocol this year. The implication of the study is almost the same like the previous one. So basically, we would like to determine if DCB or DES, new layer of DES is the better method when seeing clinically relevant in-stent restenosis by a patient. So every patient who presented with a DES ISR was included in this study, and the intervention arm was sirolimus or paclitaxel-coated balloon, which are both new generation DCBs with the 3rd generation drug-eluting stent. It was compared. And we had a device-oriented complex endpoint, which included target vessel, MI, target lesion revascularization, and late lumen loss. The novel drug-coated balloons perform as good as the 3rd generation of drug-eluting stent. That was our hypothesis for this study. And we would like to aid clinicians in choosing the correct equipment to reduce complications and improve patient outcomes. So we drafted our protocol. You could see the 3 arms of the picture, and we actually are controlling after the treatment, approximately 6 months after the index treatment with the follow-up angio, and we assess then the device-oriented complex endpoint. And also 10 to 20% of the patients goes to optical coherence tomography imaging as a subgroup analysis of this patient population. With that, we could also assess endothelium thickness and strat coverage of the lesions. So the article draft is quite finished. It's about 75%, I would say. And we plan to, we are waiting for some input yet, and then we will submit this also. And we have the target journal, again, Frontiers in Cardiovascular Medicine. So thank you for your attention, and I would like to finish with Rousseau, who said, people who know little are great talkers, while men who know much say little. Thank you.
Hello, if I can ask a question regarding the 3rd project.
Yes.
It seems that late restenosis are less responsible to drug-eluted balloons. Do you address this aspect as well during the randomized studies? So compare early and late restenosis as well, somebody?
Yes, thank you for your good question. I actually think it's very important that, as I implied in the presentation, that we should register the index procedure time. Therefore, we are also getting the information when we get a patient to include in the study, when was the index procedure, the primary stent implantation performed. So yes, we'd like to compare these results also in our clinical trial, not just in the meta-analysis.
Peter, just a provocative question. Which one would you suggest to your grandmother, DCB or DEB?
You meant DES?
DES.
Yeah, okay.
Drug-eluting stent.
Yeah, so
Drug-eluting
okay.
balloon. I'm sorry.
It depends. Actually, if my grandmother was without any comorbidities, just having a stent and low risk of stent thrombosis or recurrent in-stent restenosis, non-smoking, non-obese, then I would say drug-coated balloon. If any of the others, so basically, if any of the other important risk factors are present, I would say DES rather.